Starting now?
Good morning. Welcome to our Saturday sessions. So we've got a room full of new faces, so thanks for attending. We're going to start with Dr. Shah, whose talk is developing a medical legal neurosurgical and spine practice. Dr. Shah is from Pennsylvania and is medical director at Princeton Brain, Spine, and Sports Medicine. Dr. Shah.
Thank you so much. I appreciate you guys' time today. You know, when I was asked to give a lecture, I was thinking about doing something more technical, but I looked at the meeting agenda and I saw that was more than taken care of. And you know, wanted to make sure I also provided you guys a flavor of what we do in our practice in Princeton, New Jersey, and the suburbs of Philadelphia. We have a fairly robust neurosurgery practice. It's called Princeton Brain, Spine, and Sports Medicine. It originally started with me and my partner, who Bill knows very well, Dr. Mark McLaughlin, and we've sort of blossomed it into a very robust, thriving practice. And a large part of it is the medical legal aspect of what we do. You know, we're here when we talk about a lot of the technical components of what we do through spinal fusions and mortalities, morbidities, and things like that. And that takes up a lot of our time, a lot of our energy, a lot of our mental thought process. But then we also look at what are other ways of supplementing our practices. And in this particular region and in multiple regions throughout the country, if I've been able to travel and give similar type of talks, how do we supplement our practice? How do we use our expertise in what we do and show that we have a certain amount of legal know-how? And when you talk about a medical legal practice, we're not just talking about medical malpractice reviews and things like that. We're talking about reviews with attorneys to talk about injuries that were sustained during the course of work, during the course of car accidents, slip and falls, defending insurance companies, developing relationships, but utilizing your expertise in neurosurgery, orthopedic spine, in developing opinions about what caused the problem, how it may have caused the problem, what treatment was rendered, whether it was reasonable and necessary, and ultimately, if there's treatment to be done, can you take over care? It's another source of patient referrals, and I've been able to really engender a lot of surgeries out of this type of practice. So the first thing you have to ask yourself is, do you really want to do this? And we're all very busy doing our medical practices, running a business. If you're in private practice, it's really hard to find time between work and family for a side gig, if you will, in terms of medical legal work. But if you do want to get started with it, it is an excellent source of ancillary income in a medical practice. And getting started really is the toughest part, because once you get started, it tends to snowball. If you're an excellent expert, you're able to express your opinions in a way that lay people can really understand. And getting started really is establishing some relationships with attorneys in the area that specialize either in personal injury, defense, or plaintiff work, doing one or two of these cases, and then word of mouth spreads incredibly fast in that legal community. And then once that word of mouth spreads, what we found is we start getting a deluge of requests of how your expertise. Are you willing to review a file? Are you willing to review a record? Are you willing to see a client or patient in your office for treatment and then ultimately render opinion? Would you be willing to do an independent medical examination? These are the things that sort of get thrown at you, and if you don't understand those things, it's easy to just bat it off. But if you are able to absorb it, the next step would be to developing a staff to be able to answer a lot of these questions, because with the legal community, they really do like communication. And once you develop that staff in your office, you are able to then market your services through the website, through various sources. But ultimately, you just have to be available and time. But ultimately, non-clinical income can be a key strategy in terms of financial freedom in terms of medical practice. You know, we are being gouged here from carriers in terms of reimbursements, particularly in multi-level cases that we're doing, spine surgeries. It's harder and harder to get things authorized, you know, even if you spend a lot of time with patients. And so this may be a source of ancillary income in the midst of a number of different, you know, problems. And ultimately, one of the things that I always had to struggle with is being able to express what our payments are for something like this. But juries do expect doctors to get paid. I mean, your time is valuable, and so ultimately they do care about what your opinion is, and you're really the smartest person in the room when it comes to rendering an opinion about a medical injury as it relates to the brain, spine, or any type of orthopedic injury. And you know, you want to be able to generate some type of fee schedule, whether, and I kind of randomly got this from one of my partners, this is certainly not mine, but you know, just being able to know what your worth is and what your time value is. And again, being able to you know, expedite these types of reviews on a very frequent basis can be a very nice source of ancillary income in your practice. And you know, doing so really gives you an opportunity to not only take a step back in your own practice and evaluate what's going on, but what's going on in the medical legal community. What I've really found, what was valuable in a lot of these reviews is learning how to practice better medicine. You know, in terms of what are the expectations for us out there, in terms of how lay people view us, how they interpret what we say in the office. Are we saying enough information to them? Are we giving them enough informed consent? I revamped our informed consent forms just based on medical legal reviews alone. That saved us a time, you know? And so anytime you get an opportunity to do these types of things, it's a learning opportunity, because we get so busy in the technical aspect of what we're doing, and these are great lectures that are coming up, but in the end, we're only as good as our ability to express our thoughts to the lay public. And then ultimately testifying. You know, a lot of times you'll be asked either on a Zoom platform or in court, you know, how long have you been practicing, how many kinds of patients or procedures have you done, how much of your time is spent on medical expert witness work, you know, are you being paid to be there, explain why you're an expert, how much defense versus plaintiff work you do. These can be uncomfortable questions, but as you go on, you realize just you might be an expert for one side, they're asking the same questions on the expert on the other side. So ultimately, you're getting asked the same questions. So a lot of the hesitation I've seen with my own associates in developing a medical legal practice is some of the discomfort in the questions that you're asked. And in the end, you're trained so heavily, you're so experienced, you know what you're doing, you are the smartest person in the room, and then that'll carry across once you get experience in doing that. And ultimately, you know, when doing this type of practice, it really is an opportunity to expand another wing to your house, if you will, in terms of your medical practice. You know, once your reputation gets out there through that medical legal community, you know, you really get a rich source of patients, a rich source of knowledge, a lot of marketing opportunity to the lay public. You're really able to expand your catchment area in terms of being able to find operative candidates. And so medical legal work is not just simply reviewing records and doing an independent medical exam and testifying. It's also treating people. If you cover trauma centers, for example, we cover 2 of them, we see a fair amount of injuries, and they become our patients. And then those patients are represented by attorneys. Sometimes they'll contact us to provide expert opinions. So not only are we generating revenue through patient care, but also through the medical legal work that we're doing. And so again, that's a nice supplementary aspect of what we do. You know, I think that that's an important thing to, you know, take away from this, is that this is not necessarily an adversarial or stressful type situation, and understanding that you are the smartest person in the room and you have a certain expertise that they're willing to pay for should give you confidence to do this kind of thing, reaching out to the medical legal community, and developing that forensic side of your practice, because I think that makes you a better doctor, makes you a better spine surgeon, at least for me it did, and allowed you to really take a step back and look at your own practice and revamp what you're doing there from a protocol perspective in order to streamline things and make it much more convenient, much more safe, and certainly much more lucrative as time goes on. You know, when payments through what our medical practices, they fluctuate with the economy, they fluctuate with a number of different variables, things you can't even predict, like the pandemic. And you know, when you have that ancillary source of income, it is nice to be able to, you know, have that coming in, even though, you know, there's a lot of fluctuations and other things going on. So, you know, here we're not just trying to support or tell anyone to be a legal or go out there and be best friends with attorneys. What I'm trying to say is, you know, in order to embrace something like this, you can actually enhance your practice, not only financially, but professionally. And I think that has really taken a really big step with our practice and allowed us to expand. One of the real important aspects of it was expansion of our practice. You know, we have a very wide geographic imprint. We're not just in Princeton, New Jersey. We're in South Jersey, we're in Central New Jersey, we're in Pennsylvania. We're in a variety of different areas, and our ability to expand and put surgeons in different areas is also based on our ability to do legal work. You know, a lot of times attorney firms have clients in all these different areas, and we're able to generate referrals in those areas, so it helps to supplement growth as well and expansion. And so it's really been an interesting science, if you will. It's not been a hobby or a dabble. We've really embraced it, and we've been able to absorb that into our practice and make it into something that's really enhanced our ability to take care of people. So again, it's a very quick overview. I'm happy to take questions. I think it would be more of a Q&A. I didn't want to get too didactic.
Let me just pause for just a second and maybe have you step to the side. Sure. To start queuing up. Dr. Biswas is our next speaker. Very good. Questions?
Yes.
The last one, that whether, you know, like whether you can do the plaintiff under different.
Yes.
When such a question is asked, what's your answer?
Yeah, I mean, you know, you really have to categorize and try to estimate in your mind the percentage. I never give them total numbers. You know, that's my road answer. I say, look, I don't recall how many independent medical exams I've done, narrative reports and things like that. All I can tell you is about 5–10% of my practice is medical legal work. Of that, 60% is requests from plaintiff attorneys or patients I'm treating that I've agreed to be an expert because I believe in what I treated, and the rest were requested by defense. That's sort of the generalities of it.
One more question. Sure. Two scenarios. Well, one is like a guy who's, I do a fair amount of auto injury cases.
Yeah.
So what happens is when I get deposed for these cases, say like a guy has a cervical spine injury.
Yeah.
Okay. So he's like 45, 50 years old. He's got some stenosis here and there.
Yeah.
And then he's got some discs here and there,
Yeah.
but not really a surgical candidate.
Yeah.
But then when I get here, go for the deposition, they ask you, in your reasonable, you know those legal sentences they use, reasonable medical expertise.
Yeah.
Do you think that these discs are caused by the accident?
Right, right.
And like, you know, stenosis, we know that it's not caused by
Generative, yeah.
So when a situation is presented that way, I say that, well, before the accident, the guy was minding his own business and attending to his work, and he was not seeing doctor to doctor, from walking from doctor's office to a doctor's office. But now that's what he's doing. So I believe in what he said, but in my expertise, I mean, there are conditions that we will have, but we don't seek advice because we are not symptomatic.
Right.
Is that the way to answer, or is there a better way to answer?
No, it's a really good question. I you know, purposely didn't want to get into too many details because I know I only have 20 minutes, but you know, very common scenario is what you just said, where someone has what we perceive as a degenerative condition, which was previously asymptomatic, rendered symptomatic after an accident, mostly from a subjective standpoint. They have neck pain, radicular symptoms, no focal deficits on exam, have degenerative disc disease there that you see in your mind. You see spinal stenosis at C4 to C7, disc osteophyte complex. You're like, there's no way an accident caused these problems. And so first and foremost, you have to figure out which state you're in and what is the legal terminology. In the state of New Jersey, for example, you know, a lot of times we have to cross what we call a verbal threshold, where we have to prove that an anatomic or physiologic change had occurred to the spine. Whereas in Pennsylvania, you just have to prove an aggravation. An aggravation is a physiologic change to an injured body part without any objective change on an MRI. And that supersedes the legal, and that crosses it and allows you to do that. And you can even state that in any state, and you can be honest, and that's the best way to do it. Just be like, look, I can see that what I end up writing on the MRI review is I'll say there are, you know, C4, C5, C5, C6 disc herniations superimposed on age-appropriate changes. If the disc herniations have soft tissue characteristics, certainly those are areas that are susceptible to worsening, to aggravation, to causation. And that's where you kind of are able to express your opinion. And remember, we're not talking about 100% certainty here. We're just talking about a set of circumstances that are given to us. Patient walks into the office, we're basing our thoughts on history, medical records, physical exam, imaging, personal review, your expertise, and your training. And you're making a formulation within a reasonable degree of medical certainty or probability. That just means more likely than not. Now, if they gave you more information later, your opinion may change. But right now, that's what you think based on your expertise. Again, you always have to think, and I tell my partners all the time, it's not 100%. We're not asking, putting a gun to your head or anything. It's just simply, is it something reasonable that you can assess based on the factual evidence that's available to you?
Just curious, the audience, how many have done some legal work in the past? Very good.
Just to point out one thing, if you act as a plaintiff's expert against another neurosurgeon, you can expect to get reported to the American Board of Neurological
That's a
Surgeons.
really good point.
If you get reported to the American Board of Neurological Surgeons, you can expect to get chastised in some way, shape, or form. So the trick the plaintiff's attorneys do is to get orthopedic surgeons to testify, orthopedic spine surgeons to testify against neurosurgeons, and neurosurgical spine experts to be the plaintiff. I just would suggest it's really dirty business,
Yeah, I mean,
not good for either group to go after either group. And I've actually written to, that was done to me, and I wrote to the dean of that person was in academics. I wrote to the dean and I basically said, you have one of your faculty members is testifying against me. I think it's just got a very bad look, you know, and I added to that letter every title I ever had in my life, you know, and I can tell you how that discussion with the dean went. All the medical legal reviews in that department, I guarantee you, shut down within a week because it's embarrassing.
yeah, and I agree with that. I think when we talk about medical legal here and in side business and ancillary income, there's so much more to be gained for doing it under personal injury work with motor vehicle, you know, non-med mal. I really think that that's where we make our bones. That's where we get patients in our office. That's where we get independent reviews. We get testimonies, and we go against defense guys who then start using us on those types of cases. That's where you start developing that forensic side. The med mal, to be honest with you, that takes years off my life. I remember doing it, I was like, there's no way. In our practice, we're really hesitant on, you know, we'll do, we have a lot of relationship with defense firms, so we'll take on those cases, but it's, you know, that, we have a small community in neurosurgery. I don't know about orthopedics, but in neuro,
We all know each
it's
other.
way too small, and it's not worth the aggravation.
What percentage of your time is spent with medical legal?
Yeah, that's a good question. They always ask on testimonies.
No, I'm asking you from a personal standpoint.
Yeah,
You know, you
yeah.
practice clinical medicine.
Sure.
And of that, of the 100 hours you spend every week.
Yeah, how do you have the time
How
to do all that?
much? Yeah.
Well, so the question is ultimately, is there dedicated time that you're doing outside work, outside of your practice? And then there's also work that blends into your practice. For example, if a patient gets referred to your practice as a treating, then do you consider that medical legal work, or do you consider that patient care? Because you're treating them, you may be operating on them, and then maybe opining on causality and things like that. That's typically the case. I would say, in my case, my testimonies are usually done, I rarely go to court. I'll mostly do now, since the pandemic, everything is Zoom. It's perfect, it gives you a real opportunity to do things off hours, or cutting office hours short. Again, you have to look at the financial aspect of what you're doing, and you have to look at the institution you're at. I don't know, certain institutions may forbid you to doing it. If you're employed, if you're in private practice, you have a little more control. So it just depends on the situation. For us, it is a financial situation. Sometimes we'll get paid more on a testimony and narrative than we would on a Medicare lumbar discectomy. So why am I doing that versus that? You know what I mean? So
Can I say one other thing? Sometimes the residents think there's a way to figure out the legal side of things. There really isn't. I do a lot of defense work. I just want to say, if you practice good medicine, it is always defensible.
Yeah.
Do the best you can do. My experience is the juries understand we're only human. Things happen. You can't control every variable. Don't try to outthink. Don't order tests for defensive medicine. Just practice the best medicine you can practice. Always defensible.
well, I think when you do some of these reviews, you do realize that simplicity and common sense, and in the end, it's just communication ability. That's the one thing that we all lack. I think.
Thank you, Dr. Shah. In
So
the
thanks.
interest-
Sorry about that. Yeah.
in the interest of time, we'll pass forward with
Yep.
Dr. Biswas, and he's going to speak to us. He's
We are
from
very
Myrtle
comfortable.
Beach, South
Appreciate it.
Carolina, and we appreciate you presenting today. Thanks.
Hi, good morning. So thank you for a nice talk, Dr. Shah. Thank you. It was a nice discussion. I'm the odd man out here. I'm a trauma surgeon in Myrtle Beach. It's a real honor to be present here amongst the elite group. So I'm in Strand Hospital, which is like one of the level 1 trauma center. It's a busy level 1 trauma center. It's the biggest and the busiest in South Carolina, even in North Carolina now. And so we do a lot of traumas. When I moved over from Pittsburgh, my initial impression was that I'm moving over to a sleepy town where people are retiring, but it's far from it. We see a lot of gunshots and a lot of drug smuggling deals gone wrong and stuff like that. But today we're going to talk about a thing which is totally different. We're going to talk about people who are the elderly people who are the original inhabitants of Myrtle Beach, where they come in to retire. And those group of people, the Octagenerians and the Nonagenerians, usually previously the mindset was that rib fractures were treated conservatively, and so we used to get away from treating them operatively. Nowadays the trends have been changing from splinting, but now it's totally contraindicated that we don't splint anymore, because that increases the morbidity and mortality, increases pneumonia, increases intubation, and causes more problems for the patient. And so now the paradigm has shifted to more towards operative treatment, especially in patients who have significantly displaced fractures, and it's hampering their day-to-day lifestyle. I have no disclosure. I'm in an HCA hospital, so this is something I have to say. So we are talking about elderly versus very elderly. So there have been a lot of questions back and forth, who is an elderly person? So there's through the last couple of decades, we have number of definitions which has changed and continue to change. 60 is the new 50, and 50 is the new 40, and this sort of thing, and it keeps on going back and forth. But the normal general consensus is 65 is the age. Previously, it was some people thought it was 60 was the one. In fact, the recent time, there was a journal of trauma which came up with an article with 50 years with comorbidities. They are equally physiologically on the same platform as 65 and above. So for this discussion, we're going to take into account elderly people at 65 years of age. Who is very elderly? There's like no significant definition for that. Like there are like a couple of papers which have mentioned those, and they have like divided into three groups: 65 to 75, and then 75 to 85, and then 85 above. So they are divided into young elderly, moderately elderly, and very elderly. So that's what like they defined it. So 85 and above. So we're going to talk about the octogenarians and nonagenarians. Previously, the concept was that like we were like not operating on them because they have like significant morbidities or mortalities because of the underlying comorbidities, and so they were like a high operative risk. So the plan was to not to operate, not to touch them. But as you can see from some of the numbers here, according to WHO and the Center of the CDC, by 2030, 1/6 of the people worldwide will be over 60 years of age. And that's a significant number. By 2050, the world population over 60 years will double to 2.1 billion. And between 2020 and 2050, the number of people over 80 years of age will triple to over 426 million. So that's all a pretty significant number if you take into account this octogenarian age group. It's a paper which says about age-related diseases. As you grow older, obviously our, this is self-explanatory, our comorbidities increase, we become more frail. Frailty is important, and now it's become an integral part of some preoperative decision-making because of the reason that it is potentially reversible. So we can change the outcome if we can take care of the frailty prior to the surgery. And so that makes a difference. But frailty is important because it's vulnerability to disability, to hospitalization, to increased hospital stay, increased cost, and obviously the surgical outcome, it significantly decreases those. Chronic conditions increases as we age, and so these are some of the common for normal people like COPD, diabetes, dementia, cardiovascular diseases and stuff. Hospitalization progressively increases as you grow older, and 85 and above are like significantly higher percentage, and they're associated with functional decline. Their physiological reserves decline significantly. All of them add to their vulnerability. Again, like this is another paper which shows the same thing about management of rib fractures and mortality and morbidity increases in those age group. So rib fractures in blunt trauma usually accounts for like 12% of all trauma, and old age is significantly associated with rib fractures, especially in thoracic traumas. Elderly people are shown to have like poor outcome compared to younger people following the same sort of injury, and most likely related to this comorbidities or reduced function and reserve. And significant mortality and morbidity are associated with these rib fractures in this age group. Another paper with the same sort of theme, which talks about serious respiratory complications in this age group. Again, the mortality and morbidity increases significantly. In fact, it has doubled in this geriatric age group with almost the same sort of mechanism of injury compared to a young person. Factors contributing to those are polypharmacy, underlying chronic medical problems, frailty, nutrition, dehydration, and so on and so forth. In fact, like there's a quote from one of the Mayo Clinic articles which says that one single rib fracture in a 90-year-old person may have this individual, put the individual in as much of risk as 8 rib fractures in a 40-year-old. Again, like this is like one of the scoping reviews for elderly people and rib fractures. There's no significant current management protocol at this moment. There is a chest wall society which has come up, and it's progressively getting more and more popular. It deals with people as a specialty, and it includes like general surgeons, trauma surgeons, orthopedic surgeons, and people who are interested in doing rib fracture and surgical management of rib fractures. And they have come up with like certain protocols where like usually flail segments or patients with 3 or more displaced rib fractures, more than 50%. Those are the patients which will probably require rib plating. Other important causes are like if it significantly hampers your normal lifestyle, or the pain is so debilitating that it hampers your normal day-to-day living, then probably that makes it a candidate for rib-plating. Again, like there's another paper which talks about the management of a patient with multiple rib fractures, and we were looking for a bundled rib fracture management protocol. So as we know, like 65 and above, most of the literature is in fact like around that age group, and that's the reason I chose this article, because like we're talking about age group which is previously thought to be like those are the age groups we don't operate because they are too elderly and most of them will not make it past the surgery. So we're going to talk about that, but most of the research is around about 65 and above, because those were the ones which usually used to cause have rib fractures or falling and ground level falls and stuff like that. And the protocol was that like if you have 3 rib fractures in a 65 years of age, there's a 20% mortality or morbidity, and with each rib fractures above 3, there's a 4% increase in that. So it does have like a pretty significant implications on that. Conservative versus rib plating. So again, this is like an ongoing dilemma which is still going on, especially in this age group of octogenarians and nonagenerians. Previously, we were like trying out conservative management and pain medications and stuff, because pain is a big deal. But you have to be careful with pain medications in this age group, because narcotics, you need to be really careful about using narcotics in this age group, and because it can have like significant detrimental effects. So there's like operational considerations. Aging is associated with loss of functional reserve in all organ systems, like cardiovascular systems, pulmonary reserves, renal, hepatic system, and it's well known, and increased perioperative morbidity and mortality, and it's obvious from that. Consideration in operation on those patients, focus on multiple comorbidities, polypharmacy, and limitations, and all of those. So that makes it very, very significant, because that's been one of the hindrance previously, where surgeons used to be really careful about operating on those patients, because they were not very sure whether this patient, because of the operative risk itself, whether the patient will make it after the operation, because this is like a big enough operation where you do a thoracotomy and plate ribs. Again, some sort of a notion where it studied surgical trends, demographics, and outcomes in this octogenarians and nonagenerians, and they have like obviously higher morbidity and mortality, and this is a manuscript study which talks about increased longer post-operative period, higher perioperative mortality in this age group. So this is a case, few studies I'm going to cite, like these are like in the 65 age group, which talks about the benefits of surgical stabilization of rib fractures in this age group, and all of them like talk about the benefits, and especially when you take into account the hospitalization, the length of stay in the hospitalization, the chances of getting intubated and staying intubated in the ICU, and then like even after discharge, 50% of those like who are functional otherwise do not go back to their normal lifestyle. And so early stabilization does make a difference in this age group. And this is another few articles which talk about the same thing, that the benefits of pre-plating on the post-operative outcomes on this 65 and above age group. So these are like, again, like some of the benefits that has been proven and proven for a long period of time now. Decreased ICU stay, decreased length of stay in the hospital, decreased ventilatory requirements, decreased pulmonary complications, and also long-term pain medication requirements, and obviously decreased mortality rate, and all those like adds to the cost effectiveness of this patient. Now, what about this age group, like the elderly octogenarians and nonagenerians? Because these are like a special group where not much is written about, because it was supposed to be like isolated group. We were scared to operate on those people because of the comorbidities that we discussed. They are frail, and the chances of post-operative complications are high, and usually we tend to use conservative management for those people. So this is a case of mine This patient was 94 years of age, but she was otherwise healthy, healthy compared to her age. She was able to ambulate with a walker and stuff like that. And then I refused to operate because I've never operated on a patient like 94 years of age before with the rib plating. Maximum I've done was like 84 or something, and never done like a 95-year-old. But the patient deteriorated in 3 or 4 days. She was intubated, and this was the only isolated injury she had. Like this was a ground level fall, and this was the only isolated injury. She had multiple rib fractures, multiple displaced fractures, literally no reserve. And her daughter, who was an ICU nurse, came up to me and she Googled and said like, no, like she's going to die anyway, so why not operate on this patient? So we operated on this patient. And this is like some of the pictures from the operation. Her like ribs were really angulated, and so technically she had like literally no volume on that side of the lungs. This is like one of the important papers which talks about, it felt like this is probably the best article I could find about talking about people in the Octagenerians and Nonagenerians group. And this is like one of the largest studies which involve like 8 centers. It's retrospective in nature, but still it involves a lot of centers and a high number of patients, like around about like 1,008 or something like that, between 2015 and 2020. And their exclusion criteria was like a chest abbreviated injury score of less than 3 and a head injury score of more than 2. So basically they excluded people with a significant head injury. It's a relative contraindication for rib plating in this age group or any age group. And death obviously within like 24 hours. And a subgroup analysis compared early and late, which in our rib plating society we normally talk about that. Like usually patients benefit more from our experience if they are operated within 72 hours of the injury. And if you are late, especially that probably adds to the problem because the callus is already formed, and so the operative procedures becomes more bloody and more toilsome. But we are seeing more and more patients with malalignment, non-union, as you guys all see, in our rib plating patients coming after 3 months, 6 months because they are having persistent pain and having problems with their normal day-to-day life. Here it says like this paper significantly showed that has decreased risk of mortality in this age group compared to the non-operative group. Obviously, the important point in this paper is that like you have to be selective which patients you have to tell. Obviously, you have to take into account the family. You need to have a proper family discussion. What are the expectations and how functional these patients are, and go from there. If this, like the patient I showed, like she was literally functional because she was ambulating on her own and all with minimal, and then she recovered well. She was like extubated, and now like 6 months later, she's like barely using Tylenol PRN, so which is like really good for this age group patients. And then, so this patient group also, although like further studies needs to be done, like prospective studies and stuff, but this has definitely shown that like decreased morbidity, and if you choose correctly, those patients can also be plated and stuff like that. And in this study, what they did not, which I did not mention, was that like patients did have a significant number of ventilatory days and hospital days and stuff. But again, all these people are the ones who survived and did well post-operatively, so that's the cost that comes with the procedure. So the future focus needs to be on evaluating the risk and benefit of this surgical stabilization versus rib plating, and especially in this Octagenerian Nonagenerians. And obviously, like lots to be learned and lots to be done. And our resources are limited at this moment because we don't have enough study to back it up. But this is an ongoing process, and hopefully we'll learn a lot as we go forward. Thank you.
Thank you. Perhaps you could step to the side if there's any questions. Dr. Welch?
Two comments. Number one, half my practice is 80-year-olds, and what I've really learned is 80-year-olds are very heterogeneous. You pointed that out a few times. You have 90-year-olds who are totally functional and driving, and you have 45-year-olds who have diseases of chronic illness you wouldn't touch. So, you know, while it's convenient for us to say 80, 90, etc., it's in my experience a completely heterogeneous population.
question. So with the angulated rib fracture, what are you doing with the neurovascular bundle? Is it intact? You're trying to reapproximate?
No, so what we normally do is like, we don't normally go into the neurovascular bundle. So different plating systems are there nowadays. It's evolved a lot. So the system I normally use for elderly people is that like, again, like I have no financial gains with any company. So what we normally do is like we have a C end of the wrist, like they're like an anterior replating system where you normally go in through one cortex to the other cortex and you screw it in the other side, and the fracture is ideally in the middle so that you stabilize them. And one I used is basically with a C. So you're going in from one end of the C to the other end of the C. The advantage of that is that like when you're basically putting in the rib and it stabilizes and it reduces the fracture first. And so it doesn't get displaced when you're trying to put in the screw. And then the problem with that is that like when you're putting in the screw, it basically gets dislodged. And if you're going inferiorly, you're going into the neurovascular bundle. That's something you don't want. And then C, another advantage is that even if the bone is brittle in this 80 or 90-year-old, you're not having to do anything with the brittle bone because you're going from one end of the C to the other end. So it stabilizes like this, and you have a plate in between.
But they're only the normal treatment for rib fracture, though, in the younger population is not plating, correct?
So it depends on like how bad is the fracture.
And I spent 4 great days in the ICU with multiple rib fractures, and they were 4 of the most miserable days I could ever imagine. But yet I can't imagine having undergone surgery to plate 4 ribs would be better.
Well,
You know?
it has shown that like significantly, if you have like 50% or more displaced in 3 or more, it is probably better to have plating.
Yeah.
But like obviously they do anesthesia like now has like come up pretty good. They do serratus anterior block, rectus spinae block, and they do really very well.
Yeah. Thank you very much.
Thank you for presenting. Next up, we have Dr. Epstein, and he's going to discuss some recent trips to Honduras, neurosurgery in Honduras. Thank you.
During your break, if you happen to get a chance, next door there's a posters up from the World Surgical Foundation. So I joined that and went to Honduras a couple times, and interesting for the younger kids here. Anybody neurosurgery? So I mean, we saw stuff over there that I've been used since I was back in Bill's age, back in the 80s. Some of the tools. It's been quite interesting. I have no financial. San Pedro Sula is the second largest city in Honduras, and this is what I read about when I first went to go there. And I said, gee, it's the murder capital of the world. But now I'm very happy to say that Venezuela surpassed it. So I'm not nearly as afraid, when I first got there. Lovely town. You may recognize some of the people here. We were greeted by the mayor at the airport. There was a musical band in the background playing music. It was like a big celebration. We were a group of 12 to 14 surgeons. General surgeons, pediatric surgeons, neurosurgery, orthopedic surgeons. That pretty much rounds out. We had a plastic surgeon. So it was a quite interesting group. Along with that, we came down with nurses, CRNAs, anesthesiologists, PAs. So we had a nice group of people. I spent my days at this place. This is the main hospital in Honduras. It's around 500 beds, I think. It's a city hospital in a very, very poor town, even though it's the second largest place. They didn't have a lot of amenities, you might say. The doctor with me, Dr. Barrios, is a neurosurgeon down there. In neurosurgical residency, they take one neurosurgeon, one resident a year who trains in the capital. If you apply and you don't get that one spot, then you have to twiddle your thumbs for a year until the following year when you can either apply again to neurosurgery or apply to internal medicine or anything else. So it's not highly likely that you'll get a neurosurgical spot, but you do. They were getting some top people. And certainly Victor was not an exception. Right, kid. Just a normal day in the operating room. They dress like everybody else. The nice thing is that down there in Honduras, we could wear cloth caps like the old days we used to be able to do here in the States. I can't anymore. I don't know why every time I'm doing this, it's not changing. physician parking lot is very nicely kept, as you can tell. If it rained, it became very, very, there's a laser pointer here. Okay. It became very, these would become rivers, literally. Now this is, again, this is the city hospital, it's quite poor, but this is the private hospital parking lot. So you see there's not a lot of difference in what we had to deal with. The emergency rooms were really bright, colorful, because everybody who came in there, they brought their own colored blankets. I'm not sure if you can see it pretty well. So it was really fun to go through emergency rooms, but it's very sad because you realize so many of these people basically are going to die because there's no money, there's no funding. The private hospital has supposedly like 200 some odd ventilators sitting in storage that the country made them buy for COVID, and they're still sitting in storage. Yet all the trauma patients who come into the city hospital here, the families sit there with an ambu bag and bag them as long as possible, hoping that maybe they will get a ventilator, maybe that patient will live. If not, they just stop bagging them and the patient dies, and that's the extent of the medical care. They're familiar with all these things. Just to say that we don't have them in the hospitals, but you know, imaging, CT, MRI, you know, all standard quality. The problem was in the city hospital, the greatest device they had for imaging was called X-ray. CAT scan had broken about a year and a half since I was there last. That was the last time that was working. And the MRIs are owned outpatients. So a lot of the stuff is done outside the hospital. You come in, your back hurts, you meet a doctor, he'll give you a prescription for your MRI, you go, you have it done, you come back to the hospital and they'll operate upon you. If you're in the hospital for a long time, they'll eventually operate upon you as well. The first time I got there, we made rounds on Sunday so Dr. Berrios could show me some of the patients they wanted my help with. You know, and one was a poor gentleman who had a burst fracture, thoracic burst fracture, paraplegic, and they just want to stabilize the guy. So first they have to decide what they're going to do, and then they give the family a prescription. It'll say 8 screws, 2 rods. They go to one of the couple of hardware companies in town. It's sort of like going to Ace Hardware, but it's specialized for spine. And they go and they hand that prescription. They pay the vendor money for that, whatever they need, the 8 screws and rods. And the day of the surgery, one of the vendors come in from one of these different companies and bring in the trays just like your Stryker rep does nowadays. And they open the trays and we do the surgery. But as far as the studies, these were always done outside the hospital. So whether it's gunshot wound or subdural, et cetera, you know. This was sitting in the OR. Most of you will not remember this. I remember when this microscope came out back in the early 80s. This was the Rolls-Royce microscopes. This was called the Zeiss Contravis. The modern day ones are sort of based on this. But I mean, this was, you had to turn this wheel here to balance it, and there was a wheel here you had to turn to balance it. And then crossways, there was this wheel up here. So you had these wheels you had to turn, but it was balanced so perfectly when you're all done that literally you could take a device, put in your mouth between your lips. And you can move the scope with your just head as you're operating with 2 hands. That was the theory behind this first, very well balanced. Anyway, to say that this scope is worthless is an understatement. They only have monocular, so it doesn't help really anybody except the surgeon. They never use it. The light source is worse than, it's just pathetic. But this is what they have. Basic hardware, as I said, that's not a problem down there. We can get it. We had an issue though that we had to do something in a prone position, and their horseshoe thing had broken. So we ended up jury rigging. I used something, I forgot what I used, but it was a piece for some sort of frame that I was able to attach at least to the horseshoe. So now I had something to put the head in. But because it was only 1 post rather than 2 posts, the horseshoe kept going like this. So I ended up using a footstool to support it underneath here, you know. But you have to understand, when I trained at Kings County, this was normal. We were always doing stuff like that because everything was always breaking. So going back to Honduras, this reminds me of the old days in some way. We saw a lot of birth deformities down there, as you can imagine. I hadn't done myelomeningeal seals for quite a few years, but I remember when I was a resident, we did a ton of them, you know, and you do what you can. But there were a ton of myelomeningeal seals, tons of hydrocephalus, and babies waiting for shunts, you know, like crazy. We saw a lot of interesting pathology when we were down there. This was an interesting meningoceal. This is a gal, 14 years old, very much underdeveloped, broke her neck, car accident, tetraplegic, and she had this when I saw her. So I asked what's going on. They said, well, she started developing this like cyst or something, and they cut it open, and they found out it was just filled with fluid, technically meningoceal. So they sewed it back up, but it wasn't helping because she's still sort of seeking fluid. So they wanted to know what I would do with that. So we got a nice repair out of it. You know, the repair itself was easy. We just opened her up. And the most important thing you can do for a case like this is spinal drainage. So I made sure the anesthesiologist had a spinal drain that was working. I said to them, I said, you guys got to leave this thing in place 5 to 7 days minimum. And then we just took anything we had, the kitchen sink, you know, muscle, gel foam, anything we can, just threw it in there because obviously we didn't see a source, you know, but we knew CSF was coming out. So as long as we get some scarring and blood and did diversion, and you know, she did fine. When I showed her a picture of what she had beforehand, she goes like this, you know, because now I showed her a picture of what it looked like afterwards. Instrumentation was pretty normal, you know, standard spondees. So those things we did. Fluoroscopy was a challenge. I have an old machine. It was interesting, at least the way I was always trained is we always brought in a CR to do your AP and then sort of slid it underneath, right? And you had a drape on the other side where the CR came up or you put something over. Anyway, they would always do it over. They, for the, you know, they would, and they would, it's not like they covered the whole body, they just sort of did it over, they sort of quasi-draped it. And I was trying to tell them that's really not ideal, especially with using instrumentation, it's not really sterile. So I taught them how they could go underneath the table and put drapes up on the side, and how we could also slide it north to south to get out of the way, and it's sort of like that, you know. So once in a while, you can teach somebody something new. This is the poor guy I was telling you about that his spine was erected. But when I saw the guy, this was in late September or early October. The injury was in June. So he's been lying in bed now for 4.5 months. They're just waiting for OR time and waiting for equipment. So we just put screws and rods in the guys. Standard operating room, you know, you can see it's sort of a paucity of, normally here in the States, you have a tray that's filled with everything you can think of half the time. We saw a bunch of tumors. The goal was just really decompress. Yes, they sent some from pathology. I'm not sure where these go afterwards. They just wanted to sort of help the people out, so we would decompress the tumors. It was interesting because we're using hand burrs here. You may recognize the Codman bit. Didn't work very well on a hand. And then we use what's called a giggly saw to do the crane. You know, they don't have minus rex or anything else. So because we're operating on this brain tumor, I happen to mention, you know, people ask each day, what are you doing today? You know, and Dr. Rao would say, well, we're doing a hand reconstruction. And this one would say, well, we're doing 3 gallbladders. And I said, well, we're doing a brain tumor today. You know, and next thing you know, this is the operating room. That's our head over there, and that's where the patient is, but everybody else has to get the picture. It was a very congenial group of people. Brain tumor, I guess my slide didn't work well. We saw a fair share of trauma, of course, like you do here in the States. This is, again, run-of-the-mill stuff. But then we were also treated very nicely by the staff down there. These are some of the other, Victor was a neurosurgeon, another neurosurgeon. Likes cooking, so we go out to the local pool, we have a party, beer, and fresh meat, which is delicious. We ended up having parties here and there as well. Each night we were taken to different places. Here we have a live orchestra, and this is out there, the local club. You look at things like this, and there's such a dichotomy in the population. It's just so sad, because there is money, and obviously all these dinners that we were taken to were paid for by the supporters and the sponsors of us coming down there, of the brigade. So it was interesting. Again, you may recognize some of the faces in here. Very well treated. This is the mayor's garden. He had a nice little barbecue for us there. And I want to thank these people. Thanks.
Are there any questions?
Just practically
night. Sunday, we would go to the hospital. It was different because like where Dr. Rao went, they went to the private hospital and they did something entirely different. I was by myself at the city hospital, except for Don Allier, who was the pediatric, and then one other guy. Last year, everybody was at the city hospital, and we took over like 9 rooms. They'd never seen so much work done in that week. But it was difficult because some were working with residents and some were working with attendings, you know. So as the surgeons coming in and working with the residents, you know, are they really accomplishing a lot as opposed to some doctors want to come in and be able to do 6 gallbladders in a day and decrease the amount of people waiting for gallbladders, or 6 shunts in a day, you know. So there could be better use of our skills down there.
Thank you. Thank you. Appreciate you presenting to our group. All right, next up we have Marcel Dagley, and he's from Philadelphia. We had dinner with him last night, and he's a delightful gentleman from Austria. Very good. Dr. Day?
All right, there's some new faces, so I'll just shortly introduce myself. I'm a research fellow with the Department of Neurosurgery at the University of Pennsylvania. I primarily work with Dr. Welch, Olstruck, and Dr. Yoon. Today I'll be presenting on machine learning applications for predicting ICU stay after PSF for adult spinal deformity. And this will build a little bit on my previous presentations, as well as be a little bit more interactive and walk you through some steps and opinions as well. So these are my disclosures I've done. Overall, we know that with the increasing aging population, that the number of PSF surgeries are expected to trend up, and ICU utilization and resource management are important aspects of patient care. So our rationale for this study was that advanced machine learning models could have potentially an immense impact in resource allocation and prognosis of patient outcomes. So the purpose of the study was the development and validation of these models. This study was supported by Tripod AI and Strobe. We used our institutional spine deformity database, which was built by retrospective reviews and input from our data analytics center. Inclusion criteria was thoracolumbar-sacral spinal fusion, posterior spinal fusion with at least 6+ vertebrae in the fusion construct. For adult spinal deformity, we included 646 patients, cleaned the data, handled the missingness, filled it in, and then moved forward to predictors of action, which was identified by the literature, clinical importance and analysis, a panel of specialists, including clinicians and statisticians, as well as preliminary analysis of variables, determined which candidate predictors to include for further analysis. Literature that was used amongst others was some early studies that were published on ICU length of stay prediction and Nature scientific reports. So for ICU, as you can see, the binary, these are actually 3 different outcomes. So we built models for each of them, and as you can see, one group is ICU length of stay equal less than 7 days, or so to say, if we flip it more than 7 days, ICU length of stay more than 5 days, and ICU length of stay equal to 1 or more days. If we look at the numbers in these groups, we can see that the first group doesn't have many patients. It has like 21 patients of our overall cohort. And the second group has actually quite a more. It has 133 patients, and the last group is 453 patients. So considering these constraints, let's move forward. So we split the data in a 70-15-15 splits in the training, testing, and validation sets, and used the following models: an artificial neural network, an ensemble-boosted artificial neural network, and extreme gradient boosting. Customized all of them. Integration of more models, such as in the study presented yesterday, is ongoing. The reasons will be very clear in a moment for that, and we calculated the performance matrices on the testing set and bootstrapped to calculate confidence intervals. Methods that we used, similar as yesterday, we used the PyTorch package and built the ANN, same for the ensemble boosted ANN, and used the XGBoost package to build that one as well. So if we go to the results, we see 3 graphs here. And now keep in mind that these have different numbers of patients that we ultimately predicted. So if we look at the ICU length of stay over 1 week group or equal or less than 1 week, considering it's a binary, we can see that the XGBoost model had initially what we would assume an excellent predictive power with a discrimination of 0.94, but does anyone in the audience might see an issue with that, considering we had only 21 samples of 646 patients included? Overall, the model just said that all patients didn't. It's a binary. Either it says, if you flip it, all patients had no length of stay more than 1 week, or all patients had length of stay equal or less than 1 week. So there was a class imbalance. So 1 week might not be a good choice, which we can see when we visualize the data. If we look at ICU length of stay equal to 1 day or more, we had 453 patients in that group, and we used a bunch of predictors for that, and it had good discrimination with 0.82 and 0.81. But now let's think clinically. Is it really relevant to predict this? Is 1 day the best date to pick? Maybe not. Like clinically guided residents that discussed this with me thought 2 days or more might be more reasonable because that clinically involved might be more valuable information to have. So overall, the same as yesterday, the spectrum of explainable and opaque models should be integrated to develop the best predictive model, but include information and reasoning. Preliminary analysis revealed that this approach of developing advanced machine learning models might be valuable for ICU length of stay prediction, but you should also really focus on what kind of outcomes you want to predict, the cutoffs, what is clinically relevant, and basically your population at hand, because most of the studies, as I described yesterday, don't report on the class imbalance. They most even don't mention too much about internal validation. They just publish their results. So if you didn't know that we had like only 21 patients in that one group and read about a paper that said machine learning can excellently and very accurately predict ICU length of stay, would you really be able to know if it wasn't transparently reported? Thank you very much.
Any questions for Dr. Dag?
With any of your models here, obviously, the further you go out, the less your sample's going to be. I mean, you know, you use the same 13 predictors and look at it 1 day, 2 days, 3 days, you know, look at it that way. But either way, you're still going to have a drop-off in the group itself, you know, but maybe you'll learn more that way, perhaps. What do you have in 2 days that maybe you don't have in 4 days, and then can you notice a change? And then you can start grouping, say, 2 days, 4 days, 6, whatever. You know?
That's actually how you do it. It's very iterative. So after selecting the candidates, there is no proper guidance on how you build your ultimate model. So it's just a lot of playing around because
Trying to balance the numbers.
yeah, you're just trying to balance the numbers because ultimately there are 2 considerations. If you do it by complexity and want to integrate it in a system that has all the data, it doesn't matter. Insane amount of numbers, right? So because no one will really see, no one has to deal with it. But the way that this stuff is published, you want to do internal validation first and publish it and bring it to the people. So you want to balance the number.
Right, because you said like that group that's past 7 days or whatever, you know, it's,
Yes.
yeah, there's 4 people in it, yeah.
Yeah. So
It's annoying to us.
It is, it really is, and most of these actually, the published literature is acquired. So you can really tell most of the modes that, as I said yesterday, as in with black box modes, with these artificial brains, the AANOS, you can't really tell what's going on inside. If you can't tell what's going on inside, if they don't report on like the confusion matrix and just tell you, hey, it's got great performance, how are you gonna know as a reviewer or even a reader?
All right, up next we have Dr. Robert Minion DeMark, and he's visiting from Sioux Falls, South Dakota, and we appreciate you presenting today.
Yeah, thank you. Thanks for having us. Like on behalf of my students, thanks for the South Dakota additions here. So we'll get started here. Oops. So my topic today is talking about carpal tunnel syndrome and give you an update of what's going on. The alternative title I stole from John Fowler, Nerve Conductive Studies for Carpal Tunnel Syndrome, Gold Standard or an Unnecessary Evil. I have no disclosures. So we'll talk about carpal tunnel, how to diagnose it, what is a CTS6, and do you really need nerve studies for carpal tunnel? So we'll stick just to the facts today. And you're probably wondering what's up with this talk, because what could possibly you do about carpal tunnel syndrome? After all, first described in 1854 by Paget. Fast forward to 2024, a Google search, there are over just about 200,000 sites for carpal tunnel. And it's an interesting history from Paget. We went to 1880 Putnam, described 37 patients. In 1893, Schultz in Germany described acroparesthesia. And in 1924, the first carpal tunnel was done by Galloway. And in 1946, Can and Love at the Mayo Clinic described tardy median palsy. But as of 1950, there were only 12 reported cases of carpal tunnel surgery done. And that all changed in 1950 with George Phelan, who published several articles about median nerve compression at the wrist. And in 1966, published his landmark article of 654 hands with carpal tunnel. So this is a clinical diagnosis based on the history and physical. And in fact, you can even make this diagnosis over the phone, just give the patient a chance to tell the story. It's more common in females. Numbness in the median nerve distribution, typically night pain and numbness, aggravated by driving a car, talking on the phone, and reading a newspaper. It's a very common problem. Estimated 400,000 carpal tunnel surgeries done every year in the United States, with a total cost of $2 billion per year. And we're all familiar with the median nerve, both the motor component and the sensory distribution. Physical examination has always been a two-point discrimination, although that's really a late finding in carpal tunnel, and probably the Sims-Weinstein is a more appropriate test for that. But for motor testing, we can look at the thenar muscles and tensile strength. We're all familiar with the Phalens and the Tenels. I usually do the Jerkins, which is compression of the median nerve at the wrist crease. And we always have to think about other problems like cervical disc disease, typically C6, and that's the sensory distribution of C6 in the hand. The other differential diagnosis is what's called Lacerda syndrome or pronator, and we'll talk about that later today. We should mention electrodiagnostic studies. What are they? What are the indications? And are they needed for idiopathic carpal tunnel? Chris D. wrote a great review article in the Yellow Journal a couple years ago talking about nerve studies and described two components, the NCB, basically for nerve evaluation, and the EMG to evaluate the resting membrane potential. And the purpose has been confirmatory in the past and as a screening tool, although I think I would discourage people from using this on a fishing expedition. So clinically, carpal tunnel is used, cubital tunnel, cervical reticulopathy, and peripheral nerve injury. And just how good are they? And testing for carpal tunnel, sensitivity is between 82 and 85%. Specificity is 95 to 99%, although there's a false negative rate of 20%, perhaps even higher. And for cubital tunnel, the sensitivity is a little bit wider from 37 to 86%, and specificity greater than 95%. And in this article, he points out the sensitivity for both carpal tunnel and pupil tunnel. NCV is much more sensitive than EMG for carpal tunnel. If you do nerve studies at our place, it costs $1,000 to get one done. It means extra visits for the patients and leads to delayed treatment for 3 to 4 months because they can't do a nerve test. So what is a CTS-6? And this is a new thing you should be aware of. This is a diagnostic questionnaire that was first published in 2008 by Frank Graham, looking at the added value of electrodiagnostic testing. And his consensus was that it really did not add any probability of diagnosing carpal tunnel. This is from the articles at 6 questionnaire. This is my copy of my dictation booth. And it really has 6 parts with points. History and symptoms have 2 parts. Numbness in the median nerve distribution and nocturnal numbness. And the physical has 4 parts. Thenar, atrophy, or weakness, a positive phalanx, loss of 2-point discrimination, and a positive channel sign. And so you can add up your score after you examine the patient. If you have 12 or more points, you probably have carpal tunnel. And this is from this article showing the increase in number of points increases the probability of diagnosing carpal tunnel. And this is a pretty reliable test. This group had some patients examined by medical students, OTs, and hand surgeons, and they found substantial agreement in the exams. So anybody can do this test. It's not real hard. And diagnostic testing has kind of been the new hot button now in the hand world. Probably the best document was published by the American Academy on the Management of Carpal Tunnel Syndrome. This is 2016. They had a large work group that worked for years, generated 986-page document about carpal tunnel, which you can download for free, fortunately. It's a PDF. And their consensus, after going through all the literature, was that there's moderate evidence to support that a diagnostic questionnaire, like the CTS-6, and or electrodiagnostic testing can be done to diagnose carpal tunnel. So you don't need to do a nerve test. And this has changed, I think, the way things are being done. This study looked at the number of nerve studies done from 2016 on have dropped dramatically. So I think people are using more of the CTS-6. Who orders the nerve studies? Primary care leads the way, followed by neurology, orthopedics, hand surgeons, PM&R, rheumatology, and a group of others. You could name. So, and this is a great survey that was done on the Hand Society. They looked, had 770 hand surgeons respond about the clinical practice guidelines. So 26% of these surgeons require a nerve study before they see the patient. And 56% would between an order a nerve study if it wasn't done already. So 82% of these physicians won't see a patient without a nerve study, which of course flies in the face of the clinical practice guidelines. And then the best part is 38% felt that the clinical practice guidelines are appropriate, but 43% didn't know what the guidelines recommend. So if I were a member of the committee, I'd be a little perturbed by that. That message was not received. We should talk about ultrasound versus nerve studies. This is a great paper by John Fowler comparing ultrasound and electrodiagnostic studies. They measured the median nerve in the canal. A normal nerve is less than 10 millimeters squared. Prominent is 10 to 14 millimeters squared, and abnormal is greater than 14 millimeters squared. And they did a head-to-head comparison of ultrasound and electrodiagnostic testing. Sensitivity and specificity were the same for both groups, as opposed to positive and negative predictive value. So the conclusion was that this is a high sensitivity, specificity, and accuracy in a group of patients with a positive CTS. And Fowler took this one step further. He compared the size of the median nerve to the electrodiagnostic testing severity and found a direct correlation with the severity of nerve testing. So a normal nerve study, nerve is less than 10 millimeters. Mild carpal tunnel is 10 to 12. Moderate is 12 to 14, and severe is greater than 14. And the other advantage of using ultrasound versus nerve studies is it requires fewer medical visits, and people can have surgery earlier than with nerve studies. So this is a lot to think about, I think, for the average guy or girl. Future developments, I think we're going to be seeing more ultrasound-guided carpal tunnel injections, or releases, I mean. They have several products on the market. This is from the Mayo Clinic website showing their technique for ultrasound-guided carpal tunnel release. And after all, we are trying to improve patient care as we go along. We're all familiar with the value equation of Michael Porter, where value is defined as quality divided by cost. And we are talking about a lot of money with this diagnosis. And quality really is comprised of outcomes plus the patient experience. So I think if we can save money and not subject patients to EMGs, I think they'll be appreciative of that. And after all, I think this will probably transform the way we take care of carpal tunnel patients. So just to review the CTS exam, test your sensation, Chanel's, Phelan's, I always do the Durkin's, and then looking at the thenar muscles for motor exam. And I'm more of the Jack Sparrow school of thought as far as guidelines, not so much rules. So I think if you have a patient with a classic carpal tunnel story and a classic CTS6, I think all you need to do is the CTS6. If you do a nerve study, probably an NCB is probably enough. I think there are room for advanced studies. I think people with cervical disc disease, question of neuropathy like diabetes or ALS, nerve injury, recurrent nerve compression, failed surgery, and non-clinical picture like AIN is probably justified to do that. So the conclusions, I think we know this is the most common compression neuropathy we see. It's a clinical diagnosis. I think the CTS6 has become more important as we go along. If you do want to do nerve testing, is it worth the added expense and delay in surgery? And I think the ultrasound and the CTS6 is going to be perhaps become the new norm, and it may become the new gold standard. So back to my question, do we need nerve studies for carpal tunnel? I was working on this talk, and I had a kind of a back to the future moment. I came across a paper written by George Phelan in 1981. He kind of detailed his story of carpal tunnel and how it came about. And it's interesting, he has a statement about what he thinks about nerve studies, and that these uncomfortable, expensive tests should not be required for every patient. And that was 43 years ago, and it's probably still a true statement. So we'd like to have you think about joining the CTS6 crowd. I think you'll be happy, and your patients will be happy when you make that decision. And if you do nerve studies, just don't make a fishing trip. Thank you. Any questions?
Do you, from the authorization standpoint, did you get any feedback that you don't have any support in their studies?
Yeah, then you have to do it. Yeah, I mean, that's what you do. And you would think the insurance companies would figure this out, but I think if you're really cynical, I think the longer they can keep doing nerve studies and have that 20% false negative rate, it's a money maker for them, I think. Yes?
But it's not only the insurance companies, it's also the institutions. You know, I remember when I was still working, I couldn't book a carpal tunnel without having, you know, they wouldn't let me book in the OR without having the studies.
No, not anymore.
Yeah.
We do it in the office, came out of that.
So this is not strictly related to testing, but time and again, we see people who meet the CT6 criteria, but they also have these vague symptoms, you know, proximally radiating pain, my shoulder hurts, they've got nothing else going on, you know, it's an upper level symptom.
Right.
How do you deal with these patients? Do you tell them that their hand symptoms will disappear after surgery, or what do you talk about these proximal symptoms? You know, my elbow hurts, you know, I have shooting pain going up. What do you tell them if they're going to have surgery?
Typically, I would even, for that patient, perhaps even do a carpal tunnel injection, ultrasound guided.
Yeah.
And you can see the size of the nerve. It's kind of a 2-for-1 deal, plus see how much relief they get from symptoms. The other thing, this may be my next talk, it may be in the service for pain.
Sure.
For medium nerve, so. Yes?
Is there variability in the size of the nerve based on the size of the patient? I mean, do you look at the contralateral side, or like that, those numbers are just kind of interesting.
I think that's pretty much what it is, yeah. I haven't seen anything as far as comparing different arms. think it is. Great, thank you.
Very good, thanks, Dr. Penman. Next up, we have Andrew Alcazar, and thank you for presenting today from Chicago, Illinois.
All right, hello everyone, my name is Andrew. I come from Loyola University, Chicago. If you can't tell, there's a huge coat of arms there. Today I'm going to be presenting on differential heparin neutralization studies using protamine sulfate and a novel synthetic peptide. So I'm sure we all know what heparin is. It's a pretty common drug that we use in surgeries, especially cardiac. But heparin is a variable length glycosaminoglycan that binds to antithrombin 3. And antithrombin 3 is a certain protease inhibitor that primarily possesses anti-2A and anti-10A activity. Clinically, this manifests as higher APTT, ACT values, and smaller amplitude values in thromboelastography, which you will see in the coming slides. Using heparin can be a little bit tricky. Bleeding after heparin can be a problem, so protamine sulfate is a naturally derived protein that's indicated for reversal of various types of heparin. In the case of heparin rebound, when protamine doesn't work, you just use more protamine. So an example structure of protamine I got from an ACS Omega paper has a very arginine-rich structure here. All protamines, in fact, are arginine-rich compounds. They're found in multiple species in sperm, and it's, in fact, used for DNA packaging. And this is precisely a good characteristic for also binding heparin. The reason why is that heparin has a high number of negatively charged sulfate moieties. Protamine, since it is arginine-rich and that at physiological pH makes it quite possibly charged, can bind to heparin. So you can see here from this nice little diagram. I think I have here we go. There's a nice little diagram here that I got from a random Twitter post. You have protamine binding to heparin, and basically it sequesters it from antithrombin 3. Now, heparin increases the activity of antithrombin 3 quite a lot, and so when there is no heparin to bind to AT3, you don't get inhibition of mainly factor 10A and 2A, and so clot formation is then permitted. So there are quite a few problems with protamine. Protamine can induce pretty adverse reactions, which I will be talking about in the next slide. Additionally, supply of protamine can be limited. I will also be talking about that in a second. Protamine can either be separated from salmon sperm or it can be recombinantly produced. And then in 2021 and 2023, Fresenius Kabi reported production issues for protamine, and you can find those letters online. So with that track record, it's a little bit worrying with our supply here. So some of the adverse reactions I was referring to, you can actually read in literature. Some of those reactions include bronchospasm, severe hypotension, bradycardia, and pulmonary vasoconstriction. Literature reports that this sort of occurs around 0.06% to 10.6% of the time, although people have different estimates about that. In addition to that, there's also literature that cites mitochondrial injury, and so I'm sure there's quite a bit that we don't know that it does at other levels. One report that I found in the 85 paper was of a 55-year-old woman with diabetes, a history of hypertension, and a host of other issues. She presented to the hospital with chest pains. She was recommended to stay, and on the fourth day of stay, she received a cardiac catheterization for a cardiac angiogram, coronary artery angiogram. And during that, she was administered 5,000 units of heparin and then 20 milligrams of protamine to reverse the heparin at the end of the procedure, which resulted in severe hypotension and bronchospasms. Thankfully, they were able to perform rescue measures and she had a full recovery. The next case was pretty bad as well. A 65-year-old man, also with a host of different issues, presented to the hospital with foot ulcers. As a quick note, previous administration of protamine didn't result in any sort of adverse reaction. This was 5 years earlier. So during the visit, they noticed bilateral carotid bruits with otherwise normal expiration heart sounds and abdomen, and they also found a total occlusion of the left superficial femoral artery. So they recommended a fem-pop bypass graft, and they performed it with 10,000 units of heparin. By the end of the 45-minute procedure, they gave 50 milligrams of protamine over a period of 5 minutes, and this resulted in wheezing and cyanosis. He had a very low systolic pressure of 50 millimeters of mercury, and he was severely bradycardic. Thankfully, they were able to bring him back after intubation and also giving some vasopressors. So the question is, how do we solve the problem? Well, this novel synthetic peptide that I'm referring to is actually commercially available. It's called Heparamove. It's produced by Aniara on behalf of 5 Diagnostics. Here's some positives about it. One, it's a homogeneous single peptide as opposed to protamine, which kind of comes in a mix of different sort of, not isomers, but different forms. It's lower in molecular weight compared to protamine. It sits at around 3.12 kilodaltons. Protamines, I believe, are usually around 4 to 5. This could be less immunogenic compared to protamine. It tends to be that heavier drugs do produce immune reactions. It's also a synthetic compound, so we don't have to derive it from anywhere. We can just synthesize it ourselves. And it can also be a possible alternative for those with intolerance to the protamine-heparin complex, which is what literature suggests is the source of these immune reactions. So the purpose of this study was to compare Heparamove, which is the novel heparin antagonist, to protamine sulfate in a variety of conventional assays. As I mentioned, Heparamove was originally developed as a laboratory reagent. It's not a pharmaceutical, to reverse heparin within blood and plasma samples. I think it can be developed within the clinical arena if we give it the chance, because honestly, we need more options for reversal. So our hypothesis for this study was that Heparamove probably would have comparable reversing potential gram for gram as protamine sulfate, which we will take a look at right now. So we have the results. The methodology was to use, to compare Heparamove in neutralizing heparin to protamine in thromboelastography, see like activated clotting time, APTT, and thrombin generation, which I know is not a commonly used clinical assay. I will explain it when we get there. Okay. So firstly, thromboelastography. So the setup for this was to draw fresh blood from willing participants, and we put them in citrate tubes. We then partitioned the blood into 4 TEG cups, and we had 4 different sort of combinations. So firstly, we had a saline sample. This was just blood mixed with saline. We had porcine heparin with protamine. The porcine heparin was set at 1 microgram per mil, same with the protamine. And then we had porcine heparin plus saline, and then porcine heparin with 1 microgram per mil of Heparamove. So as you see here, this is a nice little clot. This is pretty usual for clotting. You see this nice wide amplitude. With protamine, there is a partial reversal. It did pretty well. It took a little bit longer to clot, but this is expected. And this one we were a little bit surprised by. At 1 microgram per mil, the Heparamove didn't quite do anything, actually. You can see that it's overlapping with the saline line. So just to confirm that that was correct, we actually performed it a second time, and it yielded a similar result. So just to make sure that our Heparamove was actually working, we dosed it at 10 micrograms per mil with 1 microgram per mil of heparin, and as you can see here, it took a little bit longer to clot than the protamine, but it still did its work, and it got to a similar amplitude. Next, we performed activated clotting time. So with this, we again drew fresh blood. We treated the blood with 10 micrograms per mil of heparin and 10 micrograms per mil of reversal. We also had just a saline, which was the baseline clotting, so this usually sits around, for most people, around 120, maybe up to 140 seconds. And we also had a saline plus heparin sample. So with the bovine heparin, you can see the Heparamove, which is the red, did quite well. Protamine is green, and so it did pretty good with the reversal. This is just the saline and heparin. Ovine, it also did particularly well. Protamine sits down here. This is Heparamove. The porcine sample was surprising. We had here a very wide distribution of clotting times. Protamine did well, but Heparamove was quite all over the place, and this is probably because we were only able to perform this in triplicate. It is a little bit hard to ask people to just voluntarily give their blood. So I would say if we had a larger population of people, we would probably see more of a significant difference between this heparin saline combo and the Heparamove heparin combo. Next, we perform thrombin I promised I would explain this. So thrombin is a application of fluorescent spectroscopy. You put in a fluorescent dye. In this case, we have a 7-amino-4-methylcoumarin fluorophore that's attached to an oligopeptide, and then that binds to active thrombin. Over time, you can see, you can do some nice little calculations to figure out the active concentration of thrombin, and you get these nice little graphs that we call thrombokinetograms, okay? All samples were treated with concentrations of heparin ranging from 0 to 2.5 micrograms per mil to sort of give a dose-response curve, which you will see in a moment. And samples were treated with a constant 2.5 micrograms per mil of reversal or just saline by itself. And this was measured over a period of 90 minutes. So this is the dose-response curve I was talking about. I don't really want to focus on the raw graphs. These correspond to the tops of these thrombokinetograms here, so the peak thrombin. And so you can see they correspond quite well to the reversal. So this blue line here is the saline plus the heparin. You see this nice little descent. As you increase the concentration of heparin, you would expect that the thrombin concentration would go down. With the reversals, you see that there's a resistance to the decrease in peak active thrombin. With heparin remove, it did quite well. However, you can see for all heparins, there was a significantly different potency compared to the protein. That being said, it did perform quite well, and so I think it was quite impressive. Lastly, we performed activated partial thromboplastin time. Again, with this, pooled blood bank plasma was treated with varying concentrations of heparin and 2.5 micrograms per mil of reversal. Same setup as the thrombin generation. Heparin remove and protein both produce significant decreases in APTT, as we would expect. Right here we have for all of them, the blue line corresponds to the saline sample plus heparin. Here we have heparin remove for the bovine, ovine, and then porcine. Again, porcine, since it is such a potent heparin, it does, require a bit of a higher dosing with the heparin remove, but nonetheless, it still did show quite a reversal potential. So in conclusion, heparin remove shows a lower potency than protamine sulfate, as we saw in all those assays that I presented. This might be due to the fact that heparin remove also does inhibit factor 12. So there's kind of a competition between binding to heparin and then also binding to factor 12. Nonetheless, heparin remove could be a viable alternative to protamine within the clinical arena if we adjust it for potency. So just dose more of it, and it might prove to be quite similar to protamine sulfate. So with that being said, I would just like to thank Loyola University Chicago for allowing me to conduct this research. Additionally, I have no disclosures. And thank you. Any questions?